We are starting our osteology session. Professor Subrata Mukherjee will show the, will take the osteology session.
Good afternoon to everybody. Some of the students are not acquainted with me. I am a retired professor. Formerly was HOD and Professor Medical College Kolkata, and now I am working as professor in Department of ENT JIMS, Jagannath Gupta Institute of Medical Science, Boj. Now the session which I am starting is the osteology session, and the osteology portion in the coming exam definitely will carry round about 20 marks, and you will be asked about that questions, basic question relevant to surgical part, not the morbid osteology. But here I will not deliver a lecture, just an interactive session. I will ask the question, you should answer me, and I will just recapitulate. Understand? Usually in the exam, the base of the skull and the sphenoid bone and temporal bone will be given in your exam. The multiple MS examination I have conducted as convener and non-convener, and in the different university I have taken the exam. Usually the temporal bone and sphenoid bone details, not the small bones. Here I have taken some ethmoid, palatine bone, vomer, nasal bone. But these will not be asked in the exam. Mandible, frontal bone and maxilla is with me. This is the skull base, firstly. The skull as a whole is called the upper portion and the lower portion. The upper portion is the calvaria, the calvarium. And when the calvarium is taken out, then the lower portion is the base of the skull. And this base of the skull comprises the different view. One is maybe from the upper side, that is the norma superiorlis. From the basal side, norma basalis, norma frontalis, norma occipitalis. Frontalis, usually the frontal bone commonly contributes by the maxilla and the mandible. The mandible is detachable and movable, but the other bones are fixed. Here, usually some foramens which are commonly asked in the exam, I will ask about this foramen. And this foramen lies in different fossa, anterior cranial fossa, middle cranial fossa and the posterior cranial fossa. Anterior cranial fossa, middle cranial fossa and the posterior cranial fossa. And these three line a step, means the firstly anterior cranial fossa is at a higher level, then the middle cranial fossa some lower level, then the posterior cranial fossa still lower level. These are anterior cranial fossa floor, anterior cranial fossa floor, and this floor comprised by this bone. This is the orbital plate of the frontal bone, orbital plate of the frontal bone, and in between the two orbital plate of the frontal bone there is a notch. When this bone is not articulating, that will call a notch or ethmoidal notch of the frontal bone. Ethmoidal notch of the frontal bone. Here it is the ethmoidal notch, and this ethmoidal notch has been filled up by the ethmoid. And this ethmoid comprises a two-part roof of the ethmoid comprises two parts. One part is known as fovea ethmoidalis, and medial to the fovea ethmoidalis is the cribrium plate of the ethmoid, which is perforated. Around about 15 to 20 openings are there. Olfactory nerves are piercing through this opening, and they are projecting in the olfactory valve. So, in the fovea ethmoidalis is the roof of the ethmoid on the lateral portion. In the lateral portion, medial portion of the roof is the cribrium plate of the ethmoid. Is the cribriform plate of the ethmoid. Cribrium plate of the ethmoid, and in this cribrium plate of the ethmoid, you will see a projection of bone. This projection of bone is known as the crista galli of the ethmoid. Crista galli of the ethmoid. And this crista galli of the ethmoid has an attachment with a membrane-like structure. What is that membrane-like structure? It is the falx cerebri. Falx cerebri means in between the two lobes of the brain lies a membranous structure, that is the falx cerebri. In the falx cerebri, in the cribrium plate of in this crista galli of the ethmoid, in the CT scan you will see the cribrium plate of crista galli of the ethmoid. In front of the crista galli of the ethmoid there is an opening here. Can you see? The opening, can you see? What is that opening? That opening is the foramen cecum. Foramen cecum. And this foramen, what is the importance of this foramen cecum? Here lies the superior sagittal sinus in this falx cerebri region, and here lies a vein within this foramen cecum. That vein communicates the superior sagittal sinus with the nasal vein. Superior sagittal sinus with the nasal vein. And what is the importance of knowing these structures? Today, nowadays, we do the surgical resection in the form of endoscopic surgery. Endoscopic surgery. Suppose a maxilla is extended intracranially, then with that maxillectomy procedure, we have to combine the anterior craniofacial resection. An anterior craniofacial resection, we have to go inside this cranial fossa, anterior cranial fossa, where the falx cerebri should be cut from the cribrium plate of the, from the crista galli of the ethmoid, and then frontal lobe will be retracted posteriorly by retractor, and then you can repair that area with fossa lata. That is a combined approach of anterior cranial facial resection, repair of the skull base. Then this anterior cranial fossa is bounded posteriorly. What is the structure? Posteriorly boundary of this anterior cranial fossa. Posterior boundary of the anterior cranial fossa is the posterior border of the lesser wing of the sphenoid. Can you see this lesser wing of the sphenoid? Lesser wing of the sphenoid. And these lesser wing of the sphenoid end medially in a process known as anterior crinoid process. Anterior crinoid process. And on the side of the anterior crinoid process there is a foramen. Can you see the foramen? What is this foramen? That is the optic foramen. Optic foramen. And this optic foramen is formed by two roots of the lesser wing of the sphenoids. It is bounded by the two roots of the lesser wing of the sphenoid. And then medially, this is sulcus chiasmaticus. Sulcus chiasmaticus, anterior margin of the sulcus chiasmaticus is the posterior boundary of the anterior cranial fossa in the midline. From lateral to medial is the posterior margin of the lesser wing of the sphenoid, then the anterior crinoid process, then the anterior margin of the sulcus chiasmaticus is the posterior limit of the anterior cranial fossa. Beyond that, we will enter into the middle cranial fossa. And this portion is free of any structure here. In front of the optic chiasma, this portion, though it is included in the anterior cranial fossa, and that area is smooth. What is the name of that area? Huh? Sphenoid, but plenum sphenoidally, other name, more commonly anatomical name, jugum sphenoidally. Jugum sphenoidally. This is the jugum sphenoidally. And this jugum sphenoidally in articulated skull articulates with the posterior border of the cribrium plate of the ethmoid. Posterior border of the cribrium plate of the ethmoid. Here in a sphenoid, you can see this is the jugum sphenoidally. Jugum sphenoidally. Anteriorly, the notch, ethmoidal notch, which articulates with the cribrium plate of the ethmoid. Then, this optic foramen, which is bounded by the two roots of the lesser wing of the sphenoid, What is the structure passes through these optic foramen. Through these optic foramen, what are the structure passes? The structure, important structure is the optic nerve, which is covering meninges, optic nerve. And another, any other? Ophthalmic artery. Ophthalmic artery, which is a branch of internal carotid artery. Ophthalmic artery. And these ophthalmic artery, what is the relationship of the optic nerve with the ophthalmic artery in these optic foramen? Which one will lie medial and which one will lie lateral? Medially lies the optic nerve. Inferolaterally lies the ophthalmic artery. Inferolateral. What is the practical importance of knowing these? The practical importance is that when you are going an endoscopic optic nerve decompression, endoscopically, we will approach from the medial side. From the medial side of the optic nerve. Naturally, the artery will not be injured in the procedure of optic decompression. Understand? And sometimes the central vein of retina may remain in a separate structure in these optic foramen. Three structures, one is optic nerve, another is ophthalmic artery, and then is the central vein of the retina. Then we come towards the middle cranial fossa. Middle cranial fossa. And this middle cranial fossa floor bounded laterally by the superior surface of the greater wing of the sphenoid. This is the greater wing of the sphenoid. On the superior surface of the greater wing of the sphenoid, and more laterally it is formed by the inner surface of the parietal bone. Do you know the terion and asterion? Terion and asterion, have you heard the term? The anterior inferior angle of the parietal bone, anterior inferior angle of the parietal bone is the terion, asterion is the posterior inferior angle of the parietal bone. So these areas, superior surface of the greater wing of the sphenoid, forms the more lateral part of the middle cranial fossa, but more medially it is concise in form, and it is formed by the superior surface of the body of the sphenoid. Superior surface of the body of the sphenoid. Can you see? Superior surface of the body of the sphenoid, and it is bounded anteriorly by the posterior margin of the sulcus chiasmaticus. Then there is a projection of bone here. Can you see the projection? The projection of bone is the middle crinoid process. Middle crinoid process. So this is the anterior crinoid process, this is the middle crinoid process. And sometimes there is a cartilaginous structure, which will combine this form, means the anterior crinoid process and the middle crinoid process will be converted into a canal that is known as carotico-crinoid canal. Carotico-crinoid canal, where the internal carotid artery will pass from the cavernous sinus to more anteriorly to convert in the intracerebral portion. Understand? Internal carotid artery. Then this is known as the sella turcica. The depression is the sella turcica. In your X-ray picture, CT scan picture, you will get frequently about the sella turcica. And the sella turcica is bounded anteriorly by the bony overhang, that is the tuberculum sella. Tuberculum sella. পড়েছো অ্যানাটমি পড়েছো এককালে, তাই তো? সব ভুলে গেছো? হ্যাঁ হ্যাঁ, টিউবারকুলাম সেলা, ACLLA, tuberculum sella. Then posteriorly there is a projection of the sphenoid bone, and that projection is known as the dorsum sella. Dorsum sella. Tuberculum sella and the dorsum sella, in between these two lies the sella turcica, and the deepest portion of the sella turcica lodging the pituitary gland. On the lateral side, here you can see there is an impression here. There is an impression here. This impression is for carotid artery. And here lies the cavernous sinus. Cavernous sinus with the internal carotid artery within. And if you trace posteriorly, you can go into a canal, that is the carotid canal. Ki বুঝতে পারছো? Carotid canal. And here is the foramen, is more lateral to this structure. What is this foramen? Important foramen here. ওটা দেখা যাচ্ছে? এবার বুঝতে পারছো? In the middle cranial fossa, there is a foramen here. What is this foramen? This foramen is the foramen rotundum. Foramen rotundum. And what structure passes through this foramen rotundum? Maxillary nerve. The cavernous sinus is more medial. Within the lateral wall of the cavernous sinus, the cranial nerves are there. Which cranial nerves in the lateral wall of the cavernous? Firstly 3, 4, then fifth nerve is 2 division. 2 division of the fifth nerve. So this is the position of the cavernous sinus, internal carotid artery, and this is the foramen rotundum. Foramen rotundum. And through this foramen rotundum, maxillary nerve passes. And this foramen rotundum, where it goes towards the pterygopalatine fossa. Pterygopalatine fossa means that it will open in the posterior wall of the pterygopalatine fossa. Posterior wall of the pterygopalatine fossa. And in front of these, you can see foramen rotundum. In front of these, there is a fissure. Can you see the fissure? Can you see the fissure? This is the superior orbital fissure. Superior orbital fissure means the intracranial structure will go from these middle cranial fossa to the orbit through the superior orbital fissure. And this superior orbital fissure is divided into 3 parts by a common tendinous ring. Inside annulus of gene, lateral to the annulus of gene, some structure will go through the annular tendinous communis, some structure will go, and medial to these, on the lateral surface of the body of the sphenoid, some structure will go. So what are those structures? Lateral to the annulus of gene, the structures are কি structure? বলো। Trigeminal nerve branch, ophthalmic nerve branch. Ophthalmic nerve branch is the frontal nerve, lacrimal nerve. Frontal nerve, lacrimal nerve, and trochlear nerve. And any other structures? Other structures means here lies the middle meningeal artery. Some orbital branch of the middle meningeal artery will go inside, and a recurrent meningeal branch from the lacrimal artery will go from orbit to the middle cranial fossa. সব বই আছে কিন্তু কোনোটাই মুখস্থ লেখার দরকার নেই, বুঝেছো? All are in the book. Go through the book, then you will get ophthalmic and lacrimal artery, then trochlear nerve, ophthalmic and lacrimal nerve, then trochlear nerve, then orbital branch of the middle meningeal artery, recurrent meningeal branch of the lacrimal artery, and superior ophthalmic vein. Superior ophthalmic vein, which will ultimately drain into cavernous sinus. And within the annulus of gene, there are 2 divisions of the oculomotor nerve. 2 divisions of the oculomotor nerve. In between the 2 divisions of the oculomotor nerve lies the nasociliary nerve. Nasociliary nerve and the inferior ophthalmic vein. Sometimes inferior ophthalmic vein, and important one, that is abducens nerve. All are supplying the extraocular muscle of the orbit. Eyeball. Abducens nerve. And the medial compartment, sometimes the inferior ophthalmic passes through the medial compartment. The superior orbital fissure, 3 part, lateral, medial and the medial. Okay? Then foramen rotundum already described, and this foramen rotundum, another foramen is there. Can you see the foramen? Just posterior and lateral to the foramen rotundum is another foramen that is known as foramen ovale. Foramen ovale. And what is the structure passes through the foramen ovale? Mandibular division of the trigeminal nerve, accessory meningeal artery, lesser superficial petrosal nerve, and emissary vein connecting the cavernous sinus with the pterygoid plexus. Male, MALE. But accessory meningeal artery, which artery contributes in the formation of the accessory meningeal artery? Middle meningeal artery car branch? Middle meningeal artery, branch of which artery? Internal maxillary artery. Internal maxillary artery or maxillary artery, which one? Maxillary artery. And internal maxillary artery are synonymous. Maxillary artery and internal maxillary artery are synonymous. So, what is external maxillary artery? কে বলেছো? বলেছো facial artery. Facial artery is the external maxillary artery because the internal maxillary artery lies on the internal aspect of the maxilla and external facial artery lies on the external aspect of the maxilla. And the accessory meningeal artery may be a branch from the first part of the maxillary artery. Middle meningeal artery definitely a branch of first part of the maxillary artery. Accessory meningeal artery may arise from the middle meningeal artery or may arise from the directly from the first part of the maxillary artery. The foramen ovale and the mandibular nerve passing through these goes into an area. What is that area? Mandibular nerve is passing from the intercranially to the downwards. Then downwards which area? That is the infratemporal fossa. Infratemporal fossa. Infratemporal fossa. And there is another foramen side of the foramen ovale. That is the foramen spinosum. And mainly the middle meningeal artery. And there is another nerve which is known as the nerva spinosus. Nerva spinosus is a branch of mandibular division of the trigeminal nerve. Mandibular nerve going downwards, then a recurrent branch that is known as nerva spinosus. কি হলো অসুবিধা হচ্ছে হ্যাঁ ঠিক আছে and in here the foramen ovale the lesser superficial petrosal nerve passes MALE বলেছে তো the lesser superficial petrosal nerve how it forms lesser superficial petrosal nerve how it forms and what is the function lesser superficial petrosal nerve is the secretomotor supply to the parotid gland through the otic ganglion. So, in the exam you will be asked about trace the pathway of the lesser superficial petrosal nerve. Pathway means the secretomotor pathway of the parotid gland. From the inferior salivary nucleus passes to the glossopharyngeal nerve. And the glossopharyngeal nerve contributes in the formation of a tympanic plexus, that is tympanic branch of the glossopharyngeal nerve. The tympanic plexus lies on the medial surface of the middle ear. Lies in the medial surface of the middle ear over the promontory, forming a tympanic plexus. And from that tympanic plexus, it will converge into formation of the lesser superficial petrosal nerve. And from the middle ear, it will come into the middle cranial cavity by the hiatus of the lesser superficial petrosal nerve. Can you see the hiatus? Here you can see a hiatus. Two hiatus are there. Is the greater superficial petrosal nerve, lesser superficial petrosal nerve. And this lesser superficial petrosal nerve passes through the foramen ovale, ultimately ends into the otic ganglion, postganglionic fibers through the auriculotemporal nerve distributes in the parotid gland. তো মনে থাকবে inferior salivary nucleus, glossopharyngeal nerve, tympanic branch of the glossopharyngeal nerve, then through the lesser superficial petrosal nerve, foramen ovale, then otic ganglion, postganglion fibers, and the postganglion fibers going towards the supply the parotid gland via the auriculotemporal nerve. So there is a treatment. Often, suppose a parotidoectomy has been done in the posterior, in the post-OD period, there is Fraze syndrome, and the treatment of Fraze syndrome is, or sometimes the parotid fistula also, we treat in the form of tympanic neurectomy. Tympanic neurectomy. Have you seen the tympanic neurectomy procedure? खूब simple procedure. Just tympanometal flap. After elevation, the tympanometal flap. Focus on the promontory region. You will see the plexus of the nerve. And at that plexus, if you cut the distal part of the plexus, it will cut, tympanic neurectomy will occur, and the parotid fistula will be lessened, as well as the Fraze syndrome will be. These are the practical importance of knowing this one. And sometimes in between the foramen ovale and the foramen spinosum, there is another opening that is known as canaliculus innominatus. In this bone, it is a deficient. It is not present here, and that is known as canaliculus innominatus. Through that separate opening, the lesser superficial petrosal nerve passes inside. May be there. And there may be another foramen on the medial aspect of the foramen ovale here. On the medial aspect of the foramen ovale, and that foramen is known as, that foramen is a emissary sphenoidal foramen, and the emissary vein lodges there, connecting the cavernous sinus with the pterygoid venous plexus. Then the hiatus for the greater superficial petrosal nerve. Hiatus for the greater superficial petrosal nerve. And the greater, if you trace the greater superficial petrosal nerve, it is the secretomotor supply of the lacrimal gland. Lacrimal gland, secretomotor supply. Here the superior salivary nucleus. Superior salivary nucleus. Then it will come through the sensory root of the facial nerve. Sensory root of the facial nerve. And then the first geniculate ganglion region, and then will greater superficial petrosal nerve will come as a branch, and that will go intracranial in the form of, in the opening of hiatus for the greater superficial petrosal nerve, and then it will go towards the posterior aspect of the sphenoid bone. You can see there is an opening in the posterior aspect of the sphenoid bone. Can you see the opening? This is the opening in the sphenoid. That is the opening of the pterygoid canal. Opening of the pterygoid canal. And in this pterygoid canal, this greater superficial petrosal nerve will enter as a median nerve or nerve of the pterygoid canal. And on not only the greater superficial petrosal nerve, it will communicate with a nerve known as deep petrosal nerve. Deep petrosal nerve formed by the sympathetic plexus around the internal carotid artery, and will form the median nerve or the nerve of the pterygoid canal, which will goes towards this opening through this canal, and ultimately will open into the posterior surface of the maxilla. Posterior surface of the maxilla in the pterygopalatine fossa region. In the pterygopalatine fossa region. Here you can see that the exit point of the foramen rotundum, that is the maxillary nerve. And in the anteriorly, this is the posterior surface of the pterygopalatine ganglion, posterior surface of the pterygopalatine fossa. And the nerve of the pterygoid canal will lie more medially. Nerve of the pterygoid canal opening will lie in the more medially. And in the endoscopic procedure, you will be able to see in the posterior part this opening of the median canal or median nerve. Foramen rotundum is commonly asked in the exam. Foramen ovale, foramen spinosum, hiatus for the greater superficial petrosal nerve, hiatus for the lesser superficial petrosal nerve, as well as the pathway, how it is being supplied. This is the carotid, this is the foramen lacerum. Foramen lacerum. And through this foramen lacerum, no significant structure passes. Usually it is closed with a cartilaginous structure, foramen lacerum region. But some structure in the form of limb vessel or emissary vein connecting the cavernous sinus with the pterygoid venous plexus, and some meningeal branch of the ascending pharyngeal artery may passes through it. But here lies the formation of the median nerve, a nerve of the medial canal, pterygoid canal. Here is the carotid artery, carotid canal. Can you see the carotid canal? Up to carotid canal, internal carotid artery. That's it. Internal carotid artery, and this internal carotid artery has some parts. What are those parts of this internal carotid artery? Internal carotid artery in the neck, cervical portion, no branch is there. Within the carotid canal means the anterior aspect of the middle ear, the one branch is there, carotico-tympanic artery. Carotico-tympanic artery, which pierces the wall of the carotid canal, goes inside the middle ear and anastomose with the anterior tympanic artery branch of maxillary artery. And this portion is known as the paraclival portion of the internal carotid artery. Just paraclival means the clivus, thus beside the clivus is the paraclival portion of the carotid artery, then the cavernous portion of the carotid artery, then if the carotico-sphenoid canal is there, from this area the carotid artery will ultimately bifurcate it in the form of anterior cerebral artery and middle cerebral artery. Anterior cerebral artery and the middle cerebral artery. And what are the branches of the carotid artery? First part in the carotid canal, the carotico-tympanic artery, then in the paraclival portion, thank you. Then in the paraclival portion, then in the cavernous portion. In the cavernous portion, what are the branches? Hypophyseal branch, some meningeal branch, etc. But an important branch in the intercerebral portion, that is the ophthalmic artery, anterior cerebral, middle cerebral. Circle of Willis, মনে আছে তো? আর বলছি না। Circle of Willis কখনো কখনো জিজ্ঞেস করি তখন বলতে হবে। ঠিক আছে? Then comes the posterior cranial fossa. Posterior cranial fossa. Here the posterior cranial fossa is the anterior bound of the anterior boundary or posterior boundary of the middle cranial fossa, or anterior boundary of the posterior cranial fossa is same, and that is the superior border of the petrous temporal bone. Superior border of the petrous temporal bone. And in this superior border of the petrous temporal bone, which structure lies? That is known as superior petrosal sinus. Superior petrosal sinus. And this superior petrosal sinus communicates the cavernous sinus with the junction of the transverse sinus with the sigmoid sinus. Junction of the transverse sinus and the sigmoid sinus, and this is the superior petrosal sinus. Here lies the inferior petrosal sinus. Inferior petrosal sinus means the petrous temporal bone and occipital bone, basic occiput. In between the basic occiput and the petrous temporal bone is the inferior petrosal sinus. And this is the anterior boundary of the posterior cranial fossa, superior petrosal sinus of both sides, in the middle position dorsum sella. And this is the sloping surface. This is the sloping surface forming area known as the clivus. Clivus. And that clivus formed by the basisphenoid with the basiocciput. And there is an important structure in the apex of the petrous part of the temporal bone. Here is a ligament. In the apex of the petrous temporal bone, with the petrosal process of the sphenoid bone, there is a ligament known as petrosphenoid ligament or sphenopetrous ligament or Graver's ligament. Tinta ligament. Petrosphenoid ligament or sphenopetrous ligament or Graver's ligament. And Graver, G-R-U-B-B-E-R-S. Graver's ligament. Below that ligament, there is a canal. And what is that canal? that is the Doralose canal. And through these Doralose canal passes the abducens nerve. Explaining the clinical features of Grady-Negos syndrome. Clinical features of Grady-Negos syndrome. পড়েছো তো? Complications in the form of different mastoid abscess and mastoid কি বলো 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 lateral rectus palsy, diplopia, retroorbital pain with discharge, ear discharge. ये तो undergraduate question. Grady-Negos কিন্তু post graduate জিজ্ঞেস করবো a Grady-Negos syndrome, the patient is coming to you with these features, then what are the approaches to the petrous apex? These are the post graduate question. সেই অ্যাপ্রোচগুলো পড়ে নেবে, বুঝেছো? And this posterior canal fossa is bounded posteriorly by the squamous part of the occipital bone. Squamous part of the occipital bone. And here is the internal occipital protuberance. Internal occipital protuberance. This will form the posterior canal fossa. But in the middle canal fossa, another point, in the anterior surface of the petrous temporal bone, in the anterior surface of the petrous temporal bone, there is an prominence. There is a prominence, and that prominence is the arcuate eminence. And the arcuate eminence is formed by the projection of the superior semicircular canal. Projection of the superior semicircular canal. And here is the site of superior semicircular canal dehiscence syndrome. পড়েছো তো? Superior semicircular canal dehiscence syndrome. Features, clinical features, surgical approach, endoscopic repair of the skull base. This will come into question, arcuate eminence. And the posterior surface of the temporal bone, posterior surface of the petrous temporal bone, there is an opening here, you can see. Internal auditory meatus. Internal auditory meatus, and that will lead to a canal, that is the internal auditory canal. Length koto? Internal auditory canal round about 10 millimeter, 1 centimeter. And this portion is known as the porus. This portion of the internal auditory canal is known as the porus. Lateral aspect of the internal auditory canal is known as the fundus. তারপরে তো তোমরা ডিটেলস স্ট্রাকচার জানো। And what is the structure passing through these internal auditory meatus? Two divisions of the facial nerve, vestibulocochlear nerve, internal auditory artery and internal auditory vein. Means the labyrinthine artery and labyrinthine vein. Labyrinthine artery and the labyrinthine vein. Labyrinthine artery, what is the parent artery which contributes in the formation of the labyrinthine artery is the anterior inferior cerebellar artery. Anterior inferior cerebellar artery is a branch of basilar artery. Branch of basilar artery. Vertebral artery enters then in the basilar artery, or it may be a direct branch of the basilar artery. From the anterior inferior cerebellar artery or direct branch of the basilar artery. In the fundus region, you know the structures, what is the disposition of the structures. সেটা আর বলছি না। Transverse crest, Bill's bar, anteriorly facial nerve, posterior superiorly superior vestibular nerve, anterior inferiorly tractus spinalis foraminosus, then posteriorly is the posterior vestibular nerve as the foramen singulari. Foramen singulari. This is the superior petrosal sinus area, this is the inferior petrosal sinus area, and in this area there is a venous lake. When we approach to a clival tumor or posterior canal fossa tumor by endoscopic approach through the nose, at that time these venous plexus will create a major problem. And what is that venous plexus called? In that area is known as Gulfar plexus. Gulf, G-U-L-F-A-R, Gulfar plexus. This is known as the Gulfar plexus. Here lies that Gulfar plexus. And there is another opening in this area on the posterior surface of the petrous temporal bone. Can you see? Posterior surface of the petrous temporal bone. Slit-like opening is there. Slit-like opening. And in this slit-like opening, which structure passes? That is the aqueduct of vestibuli. Aqueduct of vestibuli. Inner ear. Utricular duct, saccular duct, combinedly from utriculo-saccular duct. Then the aqueduct of vestibuli. Aqueduct of vestibuli will come through this opening, ultimately end into a sac known as endolymphatic sac. Endolymphatic sac. In the treatment of many years, we do the procedure of endolymphatic sac decompression in that area on the posterior surface of the petrous temporal bone. We have to see that area and fiber disposition of these saccus endolymphaticus. And there is an important big foramen here. Can you see the foramen? In between the articulation of the petrous temporal bone and the occipital bone, the opening is the jugular foramen. Jugular foramen. Porecho? Poroni? Nasopharyngeal angiopharma, nasopharyngeal carcinoma spreading, intracranial spread through the jugular foramen. And the jugular foramen, what structure passes through this jugular foramen? There are three portions of the jugular foramen. The foramen anteromedially, anterior part, anteromedially, middle part, and posterior inferiorly is the posterior part. Anteromedially, there is the inferior petrosal sinus. Inferior petrosal sinus will go downwards to end into the superior bulb of the interjugular vein. Superior bulb of the interjugular vein. Superior bulb of the interjugular vein, inferior petrosal sinus in the more medial portion. And in the middle portion lies the three cranial nerves. 9th, 10th, 11th. But 9th glossopharyngeal nerve will remain in a separate compartment, separate sheath, and 10th and 11th will remain in a separate sheath. And in this area, spinal accessory nerve intracranially কোথায় যায়? Spinal cord থেকে origin করার পর, from the spinal cord it goes through the foramen magnum, spinal accessory nerve, and from the foramen magnum it ultimately it combines with the cranial accessory, and from the cranial accessory and spinal accessory in the jugular foramen region, the cranial accessory fibers are carried through the vagus, but the spinal accessory will remain separate and will go through this jugular foramen downwards, ultimately come in the upper part of the neck, then supplies the sternocleidomastoid and the trapezius muscle. And the posterior part of the jugular foramen, here you can see there is an impression here. Can you see the impression here? This is the impression. What is the impression? Regularly mastoid surgery they দেখছো sigmoid sinus or lateral sinus. And this lateral sinus ultimately drain in the posterior part of the interjugular vein into the superior bulb of the interjugular vein. But interjugular vein itself not passes through the interjugular foramen. Sigmoid sinus will pass through this opening and come from the jugular bulb of the interjugular vein. ঠিক আছে? And there is another canal known as this is the occipital bone. Within this occipital bone there is a canal here. Can you see the canal? This is the hypoglossal canal. From first to last cranial nerve, how they exit from the intracranial cavity to the neck or the other areas of the face. Olfactory nerve passing through these olfactory filaments. This is cribum plate of the ethmoid. Then optic nerve through this optic foramen. Then the third oculometer through the superior orbital fissure. Then fourth, trochlear nerve, another part of the superior orbital fissure. Fifth, three division, ophthalmic, maxillary, mandibular. Ophthalmic division passes in the form of branches, frontal, lacrimal, nasociliary through the superior orbital fissure. Then maxillary division of the trigeminal nerve passes the foramen rotan nerve. Then foramen ovale, mandibular nerve. Then sixth is the abduction nerve, again superior orbital fissure. Seventh, internal auditory canal. Seventh. Eighth, vestibulocochlear, internal auditory canal. Ninth, 10th, and 11th to the jugular foramen. And 12th, hypoglossal canal, hypoglossal nerve. Clear? Here you can see the internal occipital protuberance. Here lies the confluence of the sinuses. Confluence of the sinuses, and the confluence of the sinuses usually formed by superior sagittal sinus, usually towards the transverse sinus of the right side. This is the transverse sinus, and the transverse sinus continued as the lateral sinus, ultimately forming the sigmoid sinus. Now we come to the outer portion, some of the important foramina in the outer portion of the skull. Firstly, important foramina. Can you see the opening here? Stylomastoid foramen. Just behind the root of the styloid process is the stylomastoid foramen. What structure passes through the styloid foramen? Facial nerve. Not only facial nerve, another structure is there, stylomastoid artery. Stylomastoid artery. And this stylomastoid artery is a branch of posterior auricular artery. Stylomastoid artery, branch of posterior auricular artery. And if you say the facial nerve passes through it, so you have to know the nerve, so the arterial supply of the facial nerve. Arterial supply of the facial nerve highly important from the surgical point of facial nerve decompression. The facial nerve, here is the internal auditory meatus going through the internal auditory meatus, but there is a portion of the facial nerve within the cerebellopontine angle. And in the cerebellopontine angle, the facial nerve portion is supplied by the anterior inferior cerebellar artery. Then within the internal auditory canal, it is supplied by the labyrinthine artery or internal auditory artery. Then geniculate ganglion region, then the tympanic segment of the facial nerve, geniculate ganglion and the tympanic segment is supplied by superficial petrosal artery, branch of middle meningeal artery. Superficial petrosal artery, branch of middle meningeal artery. And then the stylomastoid artery, which is a branch of posterior auricular artery. And these arterioles forms two plexus of arterioles. One is perineural plexus and one is endoneural plexus. During facial nerve decompression, you have to decompress in this form. Acha, it might have put a galo. Jago to? Acha, good. Cerebellopontine angle means the cerebellum and pons. Here, if the soft tissue are there, then it will be evident. In the internal auditory meatus region, outside this wall, intracranial cavity portion is the cerebellopontine angle tumor. And importance of cerebellopontine angle, CP-angle tumor, differential diagnosis in the CP-angle tumor. Hey, jaina ki commonly bolo. Commonly देखो cerebellopontine angle tumor acoustic neuroma, which is not within the internal auditory canal, which is projecting within the cerebellopontine, bigger one. Different stages are there. So first is acoustic neuroma, then congenital cholesteatoma is important feature. Congenital cholesteatoma, then meningioma, arachnoid cyst, These are the tumors of cerebropontine angle. আরও তিনটে আছে, এখন মনে পড়ছে না, 7টা কমনলি, বুঝেছো? cerebropontine angle, cerebropontine angle এরিয়া। কিছু বলছো? ছোট আর দেখে কতক্ষণ, আর 5 মিনিট, 5 মিনিট, আচ্ছা ঠিক আছে। This is about the maxilla. Morbid anatomy I am not describing, I am just the process of the maxillary bone, maxilla bone. This is the frontal process of the maxilla or ascending process of the maxilla, the zygomatic process of the maxilla, alveolar process of the maxilla, and this is the palatine portion, palatine process of the maxilla. Palatine portion of the maxilla. Palatine portion of the horizontal portion of the maxilla forms the hard palate, along with the articulation of the opposite side, hard palate, and this ascending process of maxilla, you know, there are 2 nasal bone here, articulating with this maxilla, 2 nasal bone, and the lacrimal bone here. Usually the lacrimal bone will not be evident here, but here lies the nasolacrimal notch. Nasolacrimal notch, just medial to this is the lacrimal bone, and in the posterior part this is the alveolar process, this is the palatine process. In the posterior part the portion of the palatine bone will be attached here, and you can see that the palatine bone is there. Can you see the palatine bone? Palatine bone, again some processes are there. The first one is orbital process. Orbital process of the palatine bone. This is the sphenoid process, sphenoidal process. Orbital process and sphenoidal process. In between the orbital process and sphenoidal process there is a notch. That is the sphenopalatine notch. Sphenopalatine notch. And this sphenopalatine notch will be converted into foramen, that is the sphenopalatine foramen, which will lie in the medial surface of the pterygopalatine fossa. Medial surface of the pterygopalatine fossa. And this portion is the horizontal process of the palatine bone. Palatine bone comprises, one is perpendicular plate of the palatine bone and the horizontal process of the palatine bone. And this horizontal process of the palatine bone articulates with the horizontal process of the opposite side, will form the posterior part of the hard palate. Posterior part of the hard palate. And on the lateral aspect of this palatine bone, which will articulate with the maxilla, posteriorly, there is a foramen, and that foramen will ultimately land into a canal, that is the gator palatine canal. Gator palatine canal, transmitting the gator palatine vessels and nerve. Gator palatine vessels and nerves. And the process which I am holding, that is the pyramidal process of the palatine bone. That is the pyramidal process of the palatine bone, and this pyramidal process of the palatine bone will fit into the area bounded by the medial pterygoid plate and the lateral pterygoid plate of the sphenoid bone. Sphenoid bone এখানে খুব ভালো নেই, এটা আর্টিকুলেটেড স্কালে দেখতে হবে। Here you can see, here you can see, দেখতে পাচ্ছ? It is a lateral pterygoid plate, medial pterygoid plate. In between the lateral pterygoid plate and the medial pterygoid plate, there is a space, and that space will occupy with the pyramidal process of the palatine bone. Then another small bone, you can see, the small bone you can see, that is a vomer. That is the vomer. Here it is the posterior border of the vomer, which will form the posterior margin of the nasal septum. Posterior margin of the nasal septum. And this portion will ultimately articulate with the more more posteriorly it will articulate with the perpendicular plate of the perpendicular plate of the ethmoid, perpendicular plate of the ethmoid, and this is the septal cartilage area. And this area will fit into the crest formed by the maxilla, the palatine process of maxilla. 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 अच्छा मैक्सिलेक्टोमी দেখেছো total maxillectomy, partial maxillectomy. Partial maxillectomy means usually we do the different forms. Alveolar process will be cut, that is a form of alveolectomy or partial maxillectomy. Another maxillectomy commonly performed in case of inverted papilloma, medial maxillectomy. Medial maxillectomy may be an open approach, may be an endoscopic approach. The medial portion of the maxilla should be cut so that whole of the maxillary antrum will be visible and all the tissues from the maxillary antrum can be removed. And here in a case of total maxillectomy, দেখা যাচ্ছে, in a total maxillectomy we will cut usually 4 to 5 cuts are given, either 4 or 5 according to the disease process. The first cut, দেখা যাচ্ছে, this is anterior ethmoidal foramen. Anterior ethmoidal foramen. We will cut this area below the anterior ethmoidal foramen, means below the skull base. We will pass a Giglis we are saw through the nasal cavity, then through this area, then we will cut this area just below the skull base, just below the first cut. Then another cut, here is the inferior orbital fissure, here is the inferior orbital fissure, can you see? From this inferior orbital fissure we will cut according to the growth. If the growth is extended more, then we will cut this one or I will cut this one. And if this lower portion, more medial portion or more anterior portion is cut, then we will cut another cut through the zygomatic arch, through this zygomatic arch. And another cut is along the hard palate, Through the nose we will pass the Giglis verso, and from the palate, in between the palate, hard palate and soft palate, we will take it out, then we will cut. And then the last attachment is towards the maxillary tuberosity here. We will cut through osteotomy. The maxilla will be separated with the growth inside. If it is an endomaxillary growth, then the easily can be taken it out. But if it is external to the maxillary cavity, then the disease prolongation is there and we have to go for a radical maxillectomy, followed by post-operative radiotherapy. The cuts according to the growth are 4 or 5. Okay. This is about mandible. Mandible commonly, this is the coronoid process, this is the condyloid process, this notch is coronoid notch, this is alveolar process, the opening is mental foramen, inferior alveolar nerve, inferior alveolar artery, here inferior alveolar artery, branch of third part of maxillary artery, and here some form of mandibulotomy or mandibulectomy are done. The first marginal mandibulectomy. Here the alveolar process, marginal mandibulectomy will remove that area. That is known as marginal mandibulectomy. Paramedian mandibulotomy. Here we will cut the mandible and this portion of the mandible will be taken out laterally so that pharyngeal tumor or base of the tongue tumor can be approached through this approach. Paramedian mandibulotomy, marginal mandibulectomy, then segmental mandibulectomy. Segmental means one segment of the mandible, according to the involvement we will take it out, that is known as segmental mandibulectomy. and hemimandibulectomy, you know. Hemimandibulectomy, you know. The growth is more expensive than as a component of commando operation. As a component of commando operation. কি আরো কন্টিনিউ করব না ছেড়ে দেবো ওদের কোশ্চেন কি আছে দেখি হ্যাঁ ইফ ইউ হ্যাভ এনি কোশ্চেন এনি কাম রিগার্ডিং দ্য অস্টিওলজি ইউ ক্যান কাট বলো কি অপারেশন রিলেটেড
Hello.
Suppose you are going for an endoscopic medial maxillectomy. Endoscopic medial maxillectomy. Inferior terminate should be cut or not? তাহলে endoscopic incision should be given. Endoscopic incision should be given below the inferior terminate, and it will include the inferior terminate so that the whole medial aspect of the maxillary antrum will be communicated. Suppose this is maxillary hiatus, the big opening is there, and during endoscopic surgery the ostium is converted into a single small cavity. What are the bones which contributes in the reduction of the size of the maxillary hiatus? Bolo? Are specific inferior nasal concha. It is the maxillary process of the inferior nasal concha inferiorly. Maxillary process of the inferior nasal concha inferiorly. Posteriorly is the perpendicular plate of the palatine bone. Perpendicular palate of the palatine bone. And superiorly, more superiorly, anterosuperiorly, anteroposteriorly. Anterosuperiorly is the descending process of the lacrimal bone with the lacrimal process of the inferior nasal concha. And more posteriorly is the uncinate process.
না যেটা মানে ওদের বলা স্যার যে পরীক্ষাতে বেসিক্যালি যে বোনগুলো
হ্যাঁ
so what are the usual bones that are usually given in exam is maxilla,
sphenoid, temporal bone, and this
temporal bone and sometimes mandible. এবারে only the detailed structure and the course are usually not asked if you are not carry very good marks or something like that. So 70 you have exceeded 70 honors marks, then you are asked about the formation of the petrosal nerve, what is pterygoid canal is formed. These are the questions then asked. But the basic questions regarding the skull base is the name of the foraminas and the structures going through. Number one, এটা হলো skull base. Regarding the mandible, different types of mandibulectomy, where segmental and marginal mandibulectomy, what are the cuts and what are the indications. This is regarding the mandible. Regarding the maxilla, the cuts of the total maxillectomy and different types of maxillectomy that sir has already elaborated. Regarding the sphenoid is again very important. Again the foraminas and the structures going through. Mainly the rotundum, oval, spinosum and the lacerum. These are the most commonly asked questions. And the must know is this one. Temporal bone. This you need to study in detail, every part. Eta bhishon mane these are very frequently asked regarding the petrous part, different parts, how it is formed, what are the different parts, what are the different foraminas and the structures, particularly the internal acoustic meatus, how it is divided and subdivided, and what are the neurovascular bundles. Neurovascular bundles are coming across. So এইগুলোই মোটামুটি জিজ্ঞেস করে তাই না?
First thing, temporal bone, which side, right or left?
Yes.
That is the important thing. Anything, it should be the side.
Regarding the maxilla, which side?
Exactly. First thing you have to proper side. Then the questions will start. Okay.
Very rarely you will
Get
ask
these.
These are the collections of sir. We will not.
Very unfortunate, then you will be given.
Separately it will not be given.
Okay.
Very difficult to preserve that bone, and very few of the teachers have a collection of ethmoid. So, do you have any question regarding the osteology?
Okay. So,
হ্যাঁ বলো বলো
Somebody has a oral polyp.
হ্যাঁ
What to comment regarding the finding of the tympanic membrane?
You cannot see the tympanic membrane, so don't comment on the
Don't comment.
tympanic membrane. But remember that mobilizing the polyp may cause vertigo. That is one type of fistula test you should not forget. Don't think about the tympanic membrane here. If it is a small polyp and the tympanic membrane is visible, it's all right. But if the polyp obscures the extraordinary canal, you describe the polyp. Whether it is filling up the polyp, whether it is mucous polyp or it is granulomatous polyp, granular polyp, or it bleeds on touch. And when you manipulate the polyp, whether the patient feels dizzy or not. So, this is the thing, and why in canal surgery?
Oral polyp related.
Sir, আছে আপনার mic দেওয়া।
Oh, regarding the oral polyp, when the oral polyp is occluding the external auditory canal, then you will not be able to see the tympanic membrane, and you have to write down that as the oral polyp is occluding the external auditory canal, I cannot comment on the tympanic membrane.
Yes, that is the thing.
But how will you perform the fistula test in that situation? How will you perform the fistula test in that situation? You have to press the polyp by the probe wrapped with the cotton, and then what is the response of the patient you see, and the fistula test either positive or negative, that can be said.
Another question. A very good question. Why in canal up surgery, revision surgery is required? It is not a revision surgery. Never consider it to be a revision surgery. It is a second look surgery.
They have trained, they will.
Canal wall up procedure. Canal wall up procedure. Canal wall up procedure is a procedure where the canal wall is preserved. So the different areas of the middle ear as well as the mastoidantrum area you will not be able to approach. Particularly the sinus tympani area. Sinus tympani area, and at that area the residual tissue will be there. And the residual tissue, if there is present, chance of
Residual cholesteatoma or
chance of
residual
recurrence is more.
tissue can be, that is the reason is the residual cholesteatoma. That is not the recurrence due to the residual disease. Recidivism. That is the reason we need to do the revision
And
surgery.
if it is a canal wall up procedure, you have to counsel the patient and the patient party that I have cleared the disease process as far as possible, but a second look surgery may be required later on, so that the reconstructive procedure will be easy. Otherwise, if you remove that as the canal wall down procedure, then reconstructive procedure will not be so easy. So the hearing preservation will be better in a canal wall up procedure, and particularly in the case of children, we will keep the patient canal wall up procedure, canal wall up technique is better acceptable. But at the same time, a pediatric cholesteatoma differs from an adult cholesteatoma. Pediatric cholesteatoma are more hostile, more aggressive, so there is chance of recurrence there.
And the mastoid is also pneumatized. So it is very difficult to eradicate the disease in children also. So canal wall up procedure, better hearing, better lifestyle. If the patient wants to swim, he or she can go for it. If we have to fit hearing aid,
ঠিক আছে?
so the hearing aid fitting becomes easier in a canal wall up, if a canal wall up procedure is done.
Thank you. for the-
So better lifestyle, hearing aid and the hearing gain.
ঠিক আছে, procedure ঠিক আছে?
But remember that after tympanoplasty or mastoidectomy, whatever it may be, you can never give the normal hearing back to the patient. In stapedotomy, you will give a normal hearing or better hearing, but in tympanoplasty, you give a better hearing but never a normal hearing. The hearing never comes back to normal.
Okay.
Any other question?
Any questions? Yes. Why?
But it should not be a routine procedure.
Routine, not a routine.
Should
First
not
thing
be a
is the
routine
medical
procedure.
legal. Second, if you do the tympanogram, two things happens. Compared to the opposite side, the ear canal volume will be more. So after the surgery, patient says that I have doubt with the surgery, whether my graft is take or not. You can repeat that tympanogram, so you can show that the air volume is reduced. So this is more on the medical legal aspect rather in the clinical aspect.
For documentation.
Documentation.
Okay, but the first point you say that I will have to assess the other ear also. If I have chronic otitis media, squamous disease in one ear, there is a very high chance of abnormal middle ear function on the other side. A number of papers have come out about the condition of the other ear in chronic otitis media, and they have a very good paper from Command Hospital also in our Bengal journal. So remember, to assess the other ear, you may have to go for impedance audiometry. Dr. Mukherjee will tell you, but one thing is for sure, that there is no definitive test that can reliably tell you that the eustachian tube is functioning or not. Even the eustachian tube is not functioning when the tympanum is perforated, the function may come back. Another is patulous eustachian tube. The eustachian tube is functioning, but it may not be effective. So, eustachian tube function is important in the outcome of tympanoplasties. But we can never be sure preoperatively whether the eustachian tube is functioning or not. So, there are some other incidental findings you have, whether patient is discharging or not, whether when you are inserting the drop, or instilling the drop, whether it is going to the nasopharynx or not, and what is the condition of the other ear. So, other ear gives you some idea about the eustachian tube and the potential of the eustachian tube to gain back its function after surgery.
Usually eustachian tube function test is not done routinely. So by assessing the other ear, by assessing the same ear, tympanoplasty is being done. And sometimes definitely after doing the tympanoplasty, eustachian tube function becomes better. But in advanced center, nowadays eustachian tube function test is being done, tested, and tuboplasty operation is done just prior to the mastoid surgery. Tuboplasty. And after doing the tuboplasty, mastoid surgery and tympanoplasty, that can be done, particularly in Delhi. In Delhi, tuboplasty, and the result of these tuboplasty procedure are waiting. We have to assess the which are better, without eustachian tube function test or with eustachian tube function test, with tuboplasty or without tuboplasty.
You will have respect from the examiners. They will ask you respectfully, what are the complications you have faced during hemithyroidectomy or total thyroidectomy? What are the difficulties you have faced during exploration of the mastoid? So what is your experience? What are your findings? So in this way, your findings, your assessment of the condition, and your idea about the disease. So everything will be asked in this way. What is your opinion? How do you proceed to manage the disease? So everything is how you do it. Okay?
I think regarding the parotid surgery, superficial parotirectomy. Superficial parotirectomy in every institute in West Bengal, we are not following the magnification. But the magnification is nowadays a fashion. It should be done in the form of either operating microscope or by loop procedure. And at the same time, neuromonitor can be applied. But these neuromonitor or modern gadgets are not solely, you should not depend on this gadget. You have to very much anatomical knowledge, you have to be very much cautious. Understand? But magnification you can use.
Any more questions?
Any questions? Otherwise, we will end.
We will sum up otherwise.
Okay. That is
One
best
thing
of luck
in the
for the
laryngectomy. In the laryngectomy procedure, there is a question discussion in the form of cricothyroid myotomy and cricothyroid myomectomy. Can you understand the question? Cricothyroid myotomy and cricothyroid myomectomy. Cricothyroid muscle, do you know? Huh? What are the parts of the cricothyroid muscle? Parts of the cricothyroid muscle is two part. One is the rectus part, means more straightened area, more medial, and more lateral area, there is oblique part. More straightened area means the cricothyroid approximation will be there done by tensing, and the tension of the vocal cord will be increased. By the oblique fiber, that will increase the tension of the vocal cord. And these cricothyroid. And this cricothyroid myotomy means the muscle only cut, the mucous membrane is preserved. Only the muscle is cut, so that the voice will, postoperative voice will be better. And myomectomy means all the muscle is cut. But myotomy is preferable than the myomectomy.
Okay. So we have the PG group. So any questions, all the teachers are there. You are also there. So any question, any doubt, you can put there. I think all teachers are available. They will give the answers. So all the best. And also try to fill up the Google feedback form. Hope best of luck for the exam.
এই কমিউনিটি স্যারেরা আমাদের জন্য এতটা করছেন এবং এক্সামের জন্য রেডি করে দিচ্ছেন, থ্যাংক ইউ ফ্রম আওয়ার সাইড, থ্যাংক ইউ ফ্রম কোর অফ আওয়ার হার্ট টু